Okay. Okay, guys, thank you for coming. This would be a quick, inshallah, quick and relatively straightforward. Okay. Okay, so let's start. So there will the format for this presentation would be not a long discussion regarding basic ECG stuff. Instead, there will be a couple of case presentations with a couple of questions. So please, whenever you see a QR code, use your phone, scan the QR code, which will direct you to a multiple choice question and answer the question. Okay. Okay, so case number 1. Okay, so this is a case that some of you might have seen. So 8 years old, just presented back in September with pale, chest pain, palpitations, and a very fast rapid heart rate of around 350 on average. So please, I'll give you a minute or two to answer this question. You guys know how to use the QR code, right? Let me remove this. I think this would be, yeah. If you guys are ready, let me know. Ready? Okay, Mervet, use the, if you can use the QR code, if you can.
Ahmed, how can they use the QR code?
You open your camera app and direct the camera app to the QR code.
So you need another phone?
Yeah, so you're using your phone to attend this lecture, then you cannot.
Yes.
Yeah.
You can send a link.
Yeah, I don't know now how to do that, so it's okay. But people, anyone try? Is it working for you guys? Anyone?
Yes, it worked with me.
Yeah. Okay. It's okay. Okay. So I think this is enough time. Okay. Okay. So guys, so anyone want to speak up before I proceed? Volunteer to say something. Anyone doesn't know this case, by the way?
I don't know this case, but I think it's VTech.
Okay, who is this? This is Marwa?
Sahar.
Sahar, okay. So Sahar, you say VTAC because? Can you explain?
White.
Yeah, white complex?
I don't see any atrial activity.
Yeah, so you see white complex.
White complex QRS.
QRSs without P waves, right?
P wave.
Okay. Okay, any other differential?
It's irregular, Mohammed, so that makes it unlikely to be a reentrant supraventricular tachycardia.
Yeah, okay. So so then your differential would be ventricular tachycardia. Any other differential?
Polymorphic VT.
Okay, so good. So it's definitely not monomorphic, right? Okay. So still VT. Any other differential?
Pre-excited WPW.
WPW.
Yeah. Okay. Okay. So okay. So good. So let's proceed. So this is how you approach such a case. Okay. So first of all, you ask yourself, is the patient stable or not? Okay. And then, definition of stable is a little bit vague, but to me, I would define stable as the patient is drowsy enough that you don't need to give anesthesia to cardiovert the patient, okay? So if the patient is wide awake, talkative, decent perfusion, decent blood pressure, I would call him stable, okay? So if the patient is stable, then you can spend some time and analyze the ECG and phone a friend and so forth, okay? If the patient is unstable, obviously you have to shock the patient immediately, okay? But in this case, the patient was stable. She was a little bit pale, but stable, okay? And then the next question would be, how would you classify such tachycardia? Obviously, it was, like you guys said, irregular, right? You see the RR interval here, for example, is shorter than this RR interval. It's polymorphic, meaning that QRS is different than this QRS, for example. And then it's wide complex for the patient. So the QRS duration is more than 120 milliseconds. And when you see such a rhythm, again, irregular polymorphic wide complex tachycardia, like you guys said, your differential will be polymorphic VT or pre-excited atrial fibrillation, meaning the patient is in AFib plus there is underlying WPW, okay? And I'll explain this further, okay? But if you want to choose between pre-excited AFib or polymorphic VT, if you pay attention to the QRSs, you could visualize, or you could see a hint of initial delta. For example, you guys you're seeing the green boxes, right? And the patient is not known to have any congenital heart disease, or there's no family history of like channelopathy or inherited arrhythmia. So statistically, it will make more sense to be pre-excited AFib rather than polymorphic ventricular tachycardia. Okay, so then going forward, there was no intervention that was done for the patient, but the rhythm changed after a couple of minutes from presentation. So this is the ECG without intervention, just the rhythm changed. Okay. So can you answer this question, please? There's another question here.
There is delta wave in ECG.
Okay, so so we can everyone see this. So there is definitely very, very short PR. Sometimes sometimes the P doesn't, the P barely ends before and then the delta is already started. So there's definitely short PR and there's delta wave, okay? So the patient, luckily spontaneously converted her AFib into sinus P waves, and the diagnosis is now more clear. There's definitely WPW, and hence the initial rhythm was pre-excited atrial fibrillation. Okay, guys, make sense? And I'll explain what is pre-excited atrial fibrillation in a second now. So first of all, let's just talk about WPW really quick. Let me move this guy. Okay, so WPW, Wolff-Parkinson-White syndrome, is, just means there is an accessory pathway that conducts atrial activation into the ventricle outside the His-Purkinje system, okay? So there's an accessory pathway between the atria and the ventricle outside the His-Purkinje system, and that accessory pathway has to conduct electrical activation from the atria to the ventricle, okay? It could be also conducting from, it may also conduct from ventricle to atria, but it has to have the antegrade function in order to see WPW on ECG. Okay, so because the usually the accessory pathway conducts atrial activation down to the ventricle faster than the normal AV node, you will get shorter PR interval. So the PR interval is a function of the atrioventricular conduction time. So because the accessory pathway conducts electrical activation faster normally than the AV node, you will get shorter PR interval. So the electric activation starts from the sinus node, goes down to the accessory pathway and activates the ventricle. And the time that it takes for the sinus node to activate the ventricle through the accessory pathway is shorter typically than the time it takes for the sinus node to activate the ventricle down the AV node. Okay, so hence you'll get shorter PR interval. And then you will also appreciate delta wave, which is defined as initial slurring of the QRS. And this is because the accessory pathway conducts down the ventricle outside the His-Purkinje system, and that ventricular myocyte activation is inefficient, through gap junctions, and hence the depolarization is slower, and hence you will see delta wave, like slowly increasing in voltage. And then by the time the His-Purkinje system is activated, you'll get steep rise of voltage and semi-normal QRS. Okay, so in combination, the QRS is like as if it's subdivided into initial delta and a normal QRS. Okay, guys. So this is why you see short PR, and this is why you see delta wave. Make sense, guys? Make sense? Yes?
Yeah, yes, yeah, Muhammad.
Okay. So in addition, when you see delta, when there is WPW, often axis of the QRS changes. Okay. For example, here, the QRS axis is positive and negative in lead 2, negative in lead 3, negative in AVF. Okay. Why is this? Because, the QRS axis is a function of the normal His-Purkinje system activation. Okay. Which is typically directs the average depolarization down to the ventricle, is typically, towards your left lower chest. Okay. Which means you will see positive QRS in the left leads, for example, lead 1, and positive QRS is in your inferior leads, for example, in lead 2, 3 AVF. Okay. However, when you have an accessory pathway, depending where that accessory pathway is located, the average depolarization across the ventricles would differ, and then it might alter the axis of the QRS. Okay, makes sense, guys? So very often when you see WW, the QRS axis would be different or altered, and that's a hint that there is something that is going on. And one of your differential when you have an abnormal QRS axis is delta wave. Okay.
What about the B axis?
The axis is same because sinus node is like normal.
Okay.
The axis changes. QRS axis changes. Okay. Furthermore, you will get, normally your Q waves are normally present in, which is, by the way, the Q wave is defined as the initial negative QRS deflection. Okay. So normally the Q waves, the normal Q waves are present in the inferior leads. Why? Because, if you guys remember from from med school, the septum is the initial ventricular depolarization starts at the septum. Okay. And then the ventricular septum is depolarized from the left ventricle side to the right ventricle side. Okay. From the left ventricle side to the right ventricle side. Okay. And then if you, as you guys know, the left ventricle is posterior and the right ventricle is anterior. Okay. So the initial QRS or the initial ventricular depolarization is directed towards the RV anteriorly. Okay. So you will see Q waves in the inferior leads. Make sense, guys? And I know it's a little bit confusing. So it's going towards the RV, it's going towards anterior. So you'll see Q waves in the inferior leads, okay? And also it's because it's going towards the right side, you might see Q waves in the left leads, mainly V6, okay? So when you don't see normal Q waves, for example, in this case, you don't see Q waves in lead 2, you don't see Q waves in V6. So this is another hint that there might be pre-excitation, okay? So this is clear, guys? So you might lose your normal Q wave, and your QRS axis might change, in addition to the short PR and delta wave, okay? So these are all hints for presence of WPW, okay? Furthermore, you know, when you have, whenever you have abnormal depolarization, for example, WPW, your repolarization, which is the SC segments and the T waves, might differ, you know, so the repolarization is dependent on the depolarization, okay? So when you have an abnormal depolarization, your SC segments might be funny, your QT might be different, your T wave might look different, but you cannot really interpret that their repolarization if you have an abnormal depolarization. For example, here, if you pay attention, you might think to yourself, okay, there is SC segment depression in V4 and V5 and V6. So is this patient having, you know, ischemia? There is Q waves in V1, you know, and so forth. There's Q waves in D3, Q waves in AVF. So you might worry about an infarct in this patient, but you know, if on further, you know, if you believe there is WW, then you know infarct is out of the picture. Okay, so in other words, WW really change your ECG significantly, and it might mimic MI, but you know, obviously the patient was not in MI. Okay, so so what is really quickly, what is the natural history of WW? Or you know, the incidence is usually 0.1 to 0.5%. You know, whenever we see patient, you know, usually they present with SVT. I mean, rarely they are asymptomatic and then incidental finding, but usually there is, you know, an SVT and then bingo, we diagnose WW. So in babies or neonates, when we treat them, when they present with SVT, usually we start therapy for 4 to 6 months, and then we stop therapy because the SVT usually goes away at 4 to 6 months of age. Okay. However, the WW pattern might persist, but just the SVT usually calms down. Okay. And then if someone presents with SVT beyond infancy, then usually that SVT would just persist. Okay, so if the patient presents with SVT in neonatally, the SVT very likely would go away. But if someone presents SVT beyond, you know, infancy, the SVT usually would persist. Okay. And then, like we said, rarely we might encounter, you know, we might diagnose WW patients incidentally, and then such patients might still be offered ablation therapy depending on risk characterizations, and sometimes the WW itself would produce ventricular dyssynchrony and dysfunction and maybe dilated ventricles. So if there is any this obvious dyssynchrony with dilated ventricles, we would offer ablation. If we believe the WW patient, the accessory pathway is persistent at maximum heart rates, we would offer ablation and so forth. Okay, even if there's no SVT. Okay, so and you know, moreover, you know, sometimes it's associated with Epstein's anomaly, for example. So we always recommend echo to screen for congenital heart disease. Okay, so what type of arrhythmias do we see with WW patients? You know, most commonly, okay, so most commonly it's atrioventricular reentry tachycardia, which is usually not life-threatening, however, may degenerate into more life-threatening arrhythmia, but typically it doesn't degenerate and it's definitely not life-threatening. This is the most common arrhythmia for WW patients, and roughly it occurs at 30 to 40% of WPW patients. Okay, so the following videos are taken from Dr. Joshua Cooper YouTube channel, which is a very nice channel that I recommend everyone to have to subscribe to it. Okay, so normally, like we said, the AV node, so this is the sinus node, this is the AV node, the conduction goes down the AV node and then through the His-Purkinje system, and there is no other way for the atria to depolarize the ventricle except through the AV node. Okay, however, when you have an accessory pathway, so the conduction goes down from A to V across the His-Purkinje system and across an accessory pathway, and then that accessory pathway would like we said, produce delta wave. Okay, sometimes the atrial activation goes down the AV node and up the pathway, and this is how SVT starts. Okay, when the conduction goes down one pathway, usually the AV node, and up the accessory pathway. Okay, so this is called this is the AVRT that mostly happen in WPW patients, but if a more serious arrhythmia, but definitely less common, is pre-excited atrial fibrillation, which is life-threatening arrhythmia, but very rare, 1 to 2% over lifetime. So like any group of patients, anyone is at risk of atrial fibrillation. However, there is higher risk for AFib in WPW patients. So when they get AFib, normally without an accessory pathway, the atria is very fast because the patient is in AFib, but the AV node doesn't conduct electrical activation very rapidly. It protects from rapid ventricular activation. However, the accessory pathway is not as smart, and then it might conduct the rapid atrial activation down to the ventricles, rapidly, like 200, 300, 400 beats per minute, and the patient might obviously go into VF. Okay, so this is why it's dangerous rhythm. Okay, so like this patient, the average heart rate was around 350 beats per minute, which is obviously very rapid. Okay, so trying to get rid of. Okay, so AFib incidence is higher in WPW patients, and the presence of the existence of accessory pathway risks rapid ventricular conduction in the setting of AFib. Okay, makes sense, guys? Yeah. Okay. And other rare arrhythmias is antidromic SVT, meaning it's going down an accessory pathway up the AV node. Okay, so usually it goes down the AV node up the accessory pathway, orthodromic tachycardia. Antidromic tachycardia is going down the accessory pathway up the AV node. So this is obviously, it's a wide complex tachycardia because it's going down the accessory pathway, and then the ventricles depolarized not through the His-Purkinje system, and you'll get wide QRS. Make sense, guys?
Yes.
So this is how this is why when you see a wide complex tachycardia, you might give adenosine, and it will convert the wide complex tachycardia if it's regular, because it will stop AV node from conducting backwards, and the tachycardia would stop. Okay, so when you see wide complex tachycardia that is regular, this is one of your differentials. Okay, and then sometimes rarely they get atrial flutter with WPW as well. Okay. Okay, so when you back to pre-excited atrial fibrillation, the acute management would be usually you want a cardiovert, or if you have procainamide, you can start procainamide. We don't have procainamide in Kuwait, so usually we just recommend cardioversion. So for this patient, by the way, the patient was presented to a general hospital, and they gave adenosine 2 times. And giving adenosine was not perfect ideal, because actually it's not recommended to give any AV nodal blocking agent during pre-excited atrial fibrillation, because you are promoting activation down the accessory pathway, and which would risk ventricular fibrillation degeneration into ventricular fibrillation. Okay, so whenever you see irregular white complex tachycardia, you should never give adenosine. Okay, obviously if the patient is unstable, you want to defibrillate, and then mind you, with defibrillation you have to use a higher energy compared to synchronized cardioversion when the patient is more stable. Okay, and then synchronized meaning you want to see the defibrillator or the AED or the your machine to be able to identify the QRS. It will mark the QRSs for you and will deliver the shock at the QRS. Okay, so this is what's meant by synchronization to the QRS. Okay, and like we said, when you have any irregular white complex rhythm, you don't want to give adenosine, you don't want to give vagal, you don't want to recommend vagal maneuvers, you don't want to give any AV nodal blocking agents such as calcium channel blocker, beta blockers, digoxin, and so forth. Okay, because you don't want to, because pre-excited AFib is one of the differentials, and you don't want to promote activation down the accessory pathway in the setting of AFib. Make sense, guys? Okay. Okay, so this was actually, this was, like we said, the treating physicians were giving adenosine incorrectly. Okay, and then such patients, because they presented with dangerous arrhythmia, usually we don't discharge the patients. We just offer ablation, and we perform ablation, and if say the ablation failed, then you might consider flecainide, high-dose flecainide, and maybe re-ablation later or so forth. But usually we don't discharge, we ablate and then discharge. Okay. So, one of the take-home messages from this presentation is don't give AV nodal blocking agent for such a rhythm. Okay. Okay, and then this is also mentioned in the AHA 2020 PEDS tachycardia with pulse algorithm. So if someone in tachycardia and then it's white tachycardia, VT is one of the differential, but it does say if the rhythm is regular and bold and monomorphic, then consider adenosine. Okay, so you have to make sure, don't give adenosine to each and every rhythm. It has to be regular and monomorphic rhythm. Okay. Okay, so I'm repeating this many times because very important information. Okay. Okay. So that's for pre-excited atrial fibrillation, but more commonly when they present with AVRT, obviously we try to cardiovert them, medically cardiovert them with adenosine. However, if you give adenosine and it stops and then keeps coming back, then it is incessant, and then you have to usually start IV therapy, such as esmolol or amiodarone, depending on the function. If the function is good, esmolol is a good choice. If the function is depressed, then maybe amio is a better choice. Okay, we don't have any other IV options. We have IV flecainide, but limitedly. Usually we only have esmolol or amiodarone. Okay, but if you give adenosine and the tachycardia converts, then usually you start oral therapy or offer ablation, and then the first line would be beta blockers. Second line is the usual flecainide, sotalol, amiodarone. And like you guys know, digoxin and calcium channel blockers are generally contraindicated for WW patients, but not for SVT patients, just WW patients. Okay, guys? Make sense? Okay, so this is what we typically do at Chest Hospital. We give adenosine. Adenosine has to stop the SVT. If it's done properly, if it's a good dose, done properly, you should see an effect. But sometimes it converts briefly and then starts back again. So then this is incessant, okay? And then usually we offer ablation when the patient is 18 kilos and above, usually 4 years and above, okay? Unless the patient is an incessant SVT and just doesn't want to stop, okay? And then for this patient, she had an accessory pathway at, just to orient you, this is the IVC here, SVC up top. This is the coronary sinus. This is your AV node, the yellow dot. And there was an accessory pathway between the CS, between the CS and the tricuspid valve down to the ventricle. So this red mark is where the accessory pathway was living. And then, this is difficult to see, but if you noted when you deliver energy, the QRS changes from, fractionated wide to, the narrow different QRS, and the PR prolongs a little bit, okay? So this is where the WW went away, okay? And then, but, you guys are used to more 12-lead ECG, so this is pre-ablation, and this is post-ablation. And like you guys, what do you guys notice differently from pre and post?
PR interval was short.
Yeah, so the PR interval prolonged a little bit, right? What else?
Yeah.
You are seeing the normal Q waves in the inferior leads. You see there's a normal Q wave here, lead 2, lead 3, lead AGF, and lead B6. Okay. I will mute you, okay? Okay.
There's axis change.
Yeah, and then the axis change. Thank you. The QRS, look, it flipped upwards, lead 2, 3 AVF, okay? So again, the ECG normalizes almost. I mean, the T wave usually takes time for it to normalize. So you see T wave inversion in the inferior leads. This is called T wave memory. So the T wave takes more time to normalize, but if you repeat this ECG probably a couple of months later, it should flip upwards, okay? But acutely, the QRS axis would change, acutely, and your normal Q waves would come back to, would be obvious as well. Okay. Okay. So okay. Okay. So we started doing ablations at Chest Hospital since January 2019. We did just recently around 100 cases, okay, just recently. So this is our results. So for non-congenital pediatric cases, the success rate is very high, 97%, recurrence rate around 11%, okay? For congenital pediatrics, success rate is a little bit lower, 86%, with recurrence rate about 29%. And for adults congenital, the success rate is less, 71%, with the recurrence rate of 26%. Okay, so that's very expected. Usually non-congenital is easier. Congenital, especially adults congenital, are usually the toughest. Okay, and then if you, this is a very recent publication from 2021. It's very similar to international. So, pediatric non-congenital ablations are, the success rate is 97%. And then, roughly, depending on what type of SVT, but it's very high. And then the congenital ablation is usually, this is for graph for congenital stuff, is down to, success rate is 81%, which is roughly the same as ours. Okay, so we definitely are, our rates are similar to international, which is good. We are also doing 0 radiation many times. We had a couple of complications, but usually in the adult congenital group. We did not have any complications in the pediatrics group, luckily. But, these good results are not, it's a team effort, obviously, from the cardiologist, the ICU, and then obviously with the EP, we are collaborating with the adults EP, and then we did a couple of workshops and, international, very, highly ranked, well-known EP, physicians. So this all is all the, everyone is why the results are, this good. Okay. So it's a team effort. Okay. So, okay. So any questions about WPW, by the way? Questions? No? Okay. So, this is case 2. Okay. Okay. Can you guys try to answer case 2? This is the last case. Okay. Should be easy. Anyone want to volunteer to answer the question?
Regular rhythm, Dr. Muhammad.
Yeah, regular rhythm
Short.
plus,
Sorry.
what else? How would you describe it? Regular plus what?
Short PR interval.
Well, you don't know where is your P? Are you seeing P waves?
Lead to, I can see.
You can see. Okay. So I'll point. This is the QRS. Where is the P? You think this is the P? Where do you think?
Yeah, I think so.
You
This
think
is
the P?
yeah, this is on. Yeah.
Okay. So I mean, where is the T? Where do you think the T is?
Okay, this could be T also.
Yeah. So there has to be a T wave after a QRS. Has to be.
Ahmed, can I point that the T for it looks like it's the speed of the paper is different.
The speed of the paper is 25 millimeter per second.
The key on the right, is it correct or wrong?
Yes, so everything is correct. Speed is correct. 10 millimeter per 1 millivolt and 25 millimeters per second. Okay. Okay, Adnan? So the heart rate here is around 250. Okay.
250.
Or
Okay.
270. It's a little bit fast. Okay. So so the QRS, that's the QRS. These are the T waves.
Yeah.
And there's no obvious P waves that you could see. I mean, you could argue there might be some P waves here and there. But this is definitely, there is a T wave. I'm not convinced there's a P wave here. Okay.
Okay.
If you ask me where do I think the P wave is, usually AVR is a good lead, or AV1 is a good lead. I think this is the QRS. This indentation after the QRS, the P, and then this is the T. Okay.
So retrograde B.
Yeah, but generally, if this is a very fast heart rate, it's not sinus tachycardia. It's way above 220. I'm not giving you history, but he's not febrile, he's not sick, he's not on isoprel, he's not on epi. There's no reason for him to be this fast. Okay.
Age also.
Age, I think he was 7 or 8 years old. So like not a baby, but young individual. And you don't see obvious P waves. So this is a narrow, complex, regular tachycardia. Okay. And then when you see narrow, complex, regular tachycardia, your differential is, SVT of some sort, of course. But like, for example, here, I'm giving you a couple of options. It's not ventricular tachycardia, definitely not. It's not AFib because it's regular. And then you have to ask your atrial tachycardia, usually it's irregular as well. So, so I said, what is the most likely rhythm? So you are between AVRT or AVNRT or flutter. And then again, if you don't think there is flutter, and then that's not the typical rate for flutter, then, the most likely rhythm would be AVRT or AVNRT. Okay.
But we can give here adenosine like
yeah.
for diagnostic.
Yeah. So again, this is narrow, usual complex tachycardia. You do not see P waves clearly. And then you want to give adenosine, especially if the patient is stable, and he was stable, and 99.9% of such patients would be stable. So you give adenosine, and then you should see, a change. If there is a flutter, you would just see the flutter waves without QRSs. And if it's truly SVT or AVRT, it should convert to sinus. It might resume, but you would see some termination before resumption. If the adenosine was given properly. In other words, large IV axis, big flush, preferably 3-way stopcock, and a good dose. At least, I usually do start 0.2 or 200 mics per kilo, if not 300 mics per kilo or 0.3 per kilo. Okay, 0.3 milligram per kilo. Okay. So just really quick, whenever you see, like we said, regular narrow complex, you believe there is, equal P waves to QRSs. In other words, you don't see P waves, it's probably hidden the QRS, but you don't see more P waves than QRSs. You would, assume it's your typical AVRT, AVNRT. Usually they are stable. You do vagal or adenosine, and you do ECG recording during the intervention to rule out flutter waves, for example. And then you do adenosine, and you should see for in this case it terminated into what, guys? What do you look for after adenosine? When it terminates, what do you want to look for?
This is atrial flutter. There is atrial flutter.
So this is the post adenosine. Where do you think there is atrial flutter?
Also, in lead 2, there is like
So-
photos.
Yeah, so again, this is PQRST, PQRST, okay?
Oh,
Okay, so not flutter, but just, sinus QRS, sinus rhythm, okay? So PQRST without, something you want to look for is delta wave, because it's associated with SVT. You don't see delta wave, okay? So this is largely normal ECG. Maybe there's T-wave inversion lead 3, which is usually non-specific, especially after an SVT episode. Otherwise, it's a normalish QR, a normalish ECG. Okay.
but QRS axis, Dr. Muhammad, in this case. It was,
But it's good. It's
no,
around
it's
90 degrees. Huh?
no, I mean in the previous ECG.
It's the same.
like-
Look, the QRSs here are exactly the same as here. So usual complex for the patient. And then, after it converts, it remained normal. Okay. During WPW, during SVT, it goes down the AV node, up the accessory pathway. So the QRS during SVT usually is normal, the QRS axis. Okay. But in sinus rhythm, the QRS with WPW, the QRS axis might be different because it's going down the accessory pathway and the AV node. But during SVT, in the setting of accessory pathway, is going down the AV node only. So axis would be different in SVT compared to in WPW. Makes sense, Ayman?
Okay, Dr. Muhammad.
Yeah, makes sense to everyone, guys. This should I repeat this?
Yes.
Repeat. Okay. So like we said, the axis in sinus rhythm in the setting of accessory pathway would be different usually because it's going down the AV node plus an accessory pathway. صح? Okay. Axis would be different. Okay. But during SVT, it will go purely down the AV node. So you'll have a normal axis like a normal, patient. Okay. During SVT, the axis would be normal. Because going down the His-Purkinje system. When the patient is converted with adenosine and he has WPW, the axis very likely would be altered because there is now activation down the AV node plus an accessory pathway, and the accessory pathway will alter the QRS axis. Make sense, Adnan?
Yeah, okay.
Yeah, but in this case, there's no accessory pathway. So the QRS in SVT is normal axis, and after adenosine, it's still normal. Okay? Okay, Dr. Ayman?
Okay, Dr. Muhammad.
Yeah? Okay. I mean, there's a little small QRS voltages in V6, but, otherwise unremarkable ECG. Okay? So, but most importantly, there's no WPW, and you will do an echo anyways. And usually, anyone with tachycardia, we usually do a screening echo anyways. Okay, okay. So again, you wanna, whenever you have narrow complex tachycardia, regular, you wanna give adenosine. And if it converts but then reinitiates, usually we start IV medications. Again, function is depressed, amio, function is good, esmolol, okay? And then such patients will be difficult to treat. Eventually, they will probably need combination therapy, okay? If it converts easily, then, oral medications, solo medications, usually beta blockers, and that's it, okay? If it doesn't convert, without any adenosine effect, obviously you have to consider other diagnoses, for example, JET, for example, okay, and so forth, okay? If it doesn't convert, truly doesn't convert, then this is usually another tachycardia, maybe atrial tachycardia or JET, but with atrial tachycardia, you should see, A's and then without QRSs, but if it's JET, you will not see much change. This requires, expert consultation, okay? But this is not very common, okay? And then after conversion, usually if it's a newborn or a baby, we usually admit, start beta blockers, make sure they tolerate beta blockers, and then discharge. If it's beyond infancy, we usually don't admit. We just start outpatient management, okay? Usually beta blockers, okay? And then for the very, very young, again, we usually start low dose of beta blocker, like for example, 1 milligram per kilo per day of Endural or propranolol, and then go up after a day or two, just to make sure there's no hypoglycemia concerns, okay? And then if the patient, if outside infancy, remember we said in infancy or when the baby is, during newborn age group, you just give therapy for 4 to 6 months and then stop medication, and usually doesn't come back. However, if the patient is beyond infancy, and usually if the patient is like 4 or 5 years and above, usually we discuss all the options for the family, including ablation, daily medications, as needed medications, or none. Meaning we tell them, if there's no WPW, we tell the family, there's no risk of pre-excited AFib, so the SVT is not dangerous by itself, except if it is chronic and the patient is not, did not seek any medical attention, which is unlikely. So we tell them, you can do nothing, and if there's palpitations, you go to the hospital, you get adenosine, but this is not very popular option. Or we can give them the option of taking propranolol as needed, meaning they get palpitations, they do vagal stuff, they take propranolol, they do vagal stuff. After 15, 20, 30 minutes, if it's not want to stop, they go to the hospital, or take daily medications, and this would prevent SVT attacks if they don't want ablation. Okay, guys? Obviously, if there's WPW, because of the risk of pre-excited AFib, we often lean more towards ablation. Okay, guys, the distinction is clear. Okay, so that's, WPW patients are treated a little bit differently than non-WPW patients. And like we said before, we cannot give digoxin, for example, we cannot give calcium channel blocker for WPW patients, okay? Okay, and many people ask me about dosages. Often amio, we start at 10 to 15 mics per kilo per minute. I don't typically give a bolus unless I'm, I'm worried about the patient, but typically I avoid boluses, or maybe just one bolus, because, especially in babies, newborns, amio might be dangerous. So if ICU people might know this, we usually just start infusion, okay? Maybe with one bolus, okay? And then sometimes we start 5, sometimes 10, sometimes 15, depending on how serious is the tachycardia and how bad is the function, okay? Obviously, if the function is bad, you might need to be more aggressive, but obviously you risk, decompensation with, high dosages of medications, but you have to be aggressive if the function is really bad, because you don't want to wait for, 4 days for the AMU levels to be decent, okay? If the function is good, we usually start esmolol. It's a very short acting, rapid or short acting medication. Half-life is less than a couple of minutes. So you start maybe 50, 100, you wait 5 minutes, and then you just keep going up until you see effect. But usually I stop at 300 mics per kilo per minute. If I don't see effect, I know that esmolol would not be very helpful, okay? Okay. And then, like we said, we don't have any other IV options, like widely available. For oral medications, we do mainly propranolol for babies. It's Q6 to Q8 dosing, but it's not a big deal. It's not a big deal for babies because they are awake, in the middle of the night very often. And I usually start 1 per kilo per day for the newborns. Otherwise, starts at 2 per kilo per day for, for the non-newborns, or, I start 1 milligram per kilo per day for newborns, but then I go up immediately. So I just make sure there's no hypoglycemia concern, okay? And then you can go up to 4, 5, or even 6 milligram per kilo per day, but I rarely go up this high. Right? Atenolol, I give atenolol if it's outside infancy, like the patient is more 2, 3 years of age and onwards. It's a PD dosing, so it's more convenient for the family. And then, if you want to, sometimes if they cannot tolerate beta blockers, for example, they have asthma, severe asthma, we can start, flecainide instead of beta blockers. But usually our first option would be beta blocker because they are the least pro-arrhythmics, okay? Other options would be flecainide, sotalol, and usually they are, BD dosing and 2 per kilo per day, 2 milligrams per kilo per day, be divided BD, okay? But usually if you want to give other medications, there is usually a reason for that. And then usually we, EPs should be heavily involved, okay? Because you have to monitor the QT for sotalol, for example, and the QRS duration for flecainide, okay? Okay, questions for the dosages, guys? And this is how we, this is how we usually approach SVT cases, okay? Clear to everyone?
Clear.
Okay, so in conclusion, we talked about WPW. It might be very subtle, so remember the hints that we mentioned. QRS axis, Q waves, short PR and delta wave, okay? Remember there is WPW might be life-threatening, especially if there is pre-excited atrial fibrillation, if the patient, had pre-excited atrial fibrillation. And then remember always to record ECG when administering adenosine and don't give adenosine for any irregular rhythm, okay? And then the ablation therapy results are good. So, often, we eventually, most of such cases will eventually undergo ablation because the results are good, okay? Okay. Questions, guys?
السلام عليكم دكتور محمد.
سلام.
هو سؤال واحد بس اللي هي يعني ده فيرست سلايد اول واحده خالص بتاعت اللي هو الفايبريليشن مع الدبليو بي دبليو. دي نقدر نفرقها بينها وبين البتاع اللي هي الفي تي بايه؟
You cannot it's irregular. Okay, so if it's VT, it's not monomorphic regular VT, it's polymorphic regular VT. But you cannot swear that it's one or the other, except if you look at the ECG. If you think there is an initial, if you look very carefully, you get the hint that there is a slurring. The onset of the QRS is slurred. Okay, and so that's a hint. Plus the patient is a normal individual. There's no congenital heart disease. There's no electrolyte disturbance. There is no, polymorphic. There's no, family history of sudden death here and there. So there is, getting polymorphic VT in someone is a little bit unusual. Usually without in someone who is very healthy and no family history of concern and, no specific trigger. Okay. So, but either way, you have to cardiovert such rhythm. You cardiovert such rhythm, and then if you see WW after cardioversion, then you have the diagnosis. If you don't, then it's more polymorphic VT for whatever reason. Okay, but statistically, it's more common to see pre-excited AFib than polymorphic VT. Usually polymorphic VT as well. People usually don't tolerate polymorphic VT as good as like young pediatric age group. Usually, polymorphic VT is probably more malignant than pre-excited AFib. Okay. But it's a differential diagnosis, and anyways, the treatment would be the same cardioversion. Okay. Stable cardioversion, unstable defibrillation. Okay. You cannot do much, otherwise. Okay. You have to cardiovert. Okay. It's a good question. Any other question? But that's a very common exam question. So it usually shows up on boards. Like one of the EP questions would be about pre-excited AFib. It's a rare ECG, but we just had this patient is one of ours that presented in September. So it happens, and it is everyone should recognize it because it is treatable but life-threatening, and you don't want to give adenosine. So so it's it should be well recognized. Okay. So this baby, Twelly, I think when you were traveling, not baby, this patient was admitted when you were traveling, so you did not get to see her. Okay. I see such a patient once every 4 years, 5 years. So it's not very common, This is the first time I see such, in pediatrics, I mean, in Kuwait since 4 years. This is the first time. And then when I was abroad, I saw it once or twice only. So it's not very common, In adults, they probably see it a little bit more than us, but it's definitely, this is 8 years old only. So why would an 8 years old get AFib? It's a little bit, definitely happens, but uncommon. Okay. And when you get rid of when you ablate the patient, usually the AFib risk comes down as well. And usually they are not, they don't show up later with AFib, and we do not treat her AFib, we just treat the accessory pathway, and usually the AFib improves. Okay. So she's discharged from clinic, no medications. So we are comfortable that, that she should not get any bad arrhythmias anymore. I told the dad to, I think I told the dad, you're discharged, but he told me that I want to come back in 6 months. So I said, fine. But I think I technically discharged the patients, maybe a little bit prematurely, but I think I told them you're discharged, so. Okay. Questions, guys? Any more questions? No?